The International Classification of Diseases, ICD-11 grouping of schizophrenia, and other primary psychotic disorders replaces the ICD-10 grouping of schizophrenia, schizotypal, and delusional disorders. The term primary indicates that psychotic processes are a core feature, in contrast to psychotic symptoms that may occur in other disorder. Updates in ICD-11, Schneiderian first-rank symptoms has been de-emphasized and all subtypes of schizophrenia removed. A set of dimensional descriptors has been introduced. These include positive, negative, depressive mood, manic mood, psychomotor and cognitive symptoms. ICD-11 schizoaffective disorder still requires the near-simultaneous presence of both the schizophrenia syndrome and a mood episode. The diagnosis is meant to reflect the current episode of illness and is not conceptualized as longitudinally stable. As in the ICD-10, schizotypal disorder is classified in primary and other psychotic disorder. ICD-11 acute and transient psychotic disorder corresponds only to the polymorphic form of acute psychotic disorder in the ICD-10. Non-polymorphic subtypes of acute psychotic disorder in the ICD-10 have been eliminated and would instead be classified in the ICD-11 as other primary psychotic disorder. Diagnostic requirements of schizophrenia or other primary psychotic disorders. Schizophrenia or other primary psychotic disorders is a grouping of disorders characterized by significant impairments in reality testing and alterations in behavior as manifested by symptoms such as delusions, hallucinations, formal thought disorder, typically manifested as disorganized speech, and disorganized behavior. They may be accompanied by psychomotor disturbances and negative symptoms, such as blunted or flat affect. These symptoms do not occur primarily as a result of substance use, hallucinogen intoxication, or another medical condition, for example, Huntington disease. The disorders in this grouping are referred to as primary psychotic disorders because psychotic symptoms are their defining feature. Psychotic symptoms may also occur in the context of other mental disorders, but in these cases the symptoms occur alongside other characteristic features of those disorders. Whereas experiences of reality loss/distortion occur on a continuum, and can be found throughout the population, disorders in this group represent patterns of symptoms and behaviors that occur with sufficient frequency and intensity to deviate from expected cultural or subcultural expectations. Schizophrenia or other primary psychotic disorders include the following: 6A20 schizophrenia. 6A21 schizoaffective disorder. 6A22 schizotypal disorder. 6A23 acute and transient psychotic disorder. 6A24 delusional disorder. 6A2Y other specified. In the context of schizotypal disorder, symptoms may be substantially attenuated such that they may be characterized as eccentric or peculiar rather than overtly psychotic. The categories in the grouping of schizophrenia or other primary psychotic disorders should not be used to classify the expression of ideas, beliefs, or behaviors that are culturally sanctioned. Many religious or cultural practices worldwide incorporate experiences qualitatively similar in nature to the symptoms described for this grouping of disorders, and these should not be considered to be pathological. For presentations characterized by psychotic symptoms that do not fulfill the diagnostic requirements, for example, in severity, frequency, or duration, for any other disorder in the schizophrenia or other primary psychotic disorders grouping, the following diagnosis may be appropriate: 6A2Y other specified primary psychotic disorder. General cultural considerations for schizophrenia or other primary psychotic. 1. Disorders' beliefs vary across cultures, such that those considered odd or unusual in one culture may be normative in another. For example, belief in witchcraft or supernatural forces. Distress may be expressed in ways that may be misinterpreted as evidence of psychotic symptoms, such as pseudo-hallucinations and overvalued ideas or dissociative experiences related to trauma. 2. In some cultures, distress due to social circumstances may be expressed in ways that can be misinterpreted as psychotic symptoms, for example, overvalued ideas and pseudo-hallucinations, but that instead are considered normal for the person's subgroup. 3. Symptom presentation of schizophrenia or other primary psychotic disorders may vary across cultures. For example, the content and form of hallucinations, visual hallucinations are more common in some cultural groups and in some countries, or delusions, making it difficult to differentiate among culturally normal experiences, overvalued ideas. For instance, in several cultures, for example, southern China, Latin America, it is common to expect the spirit of a deceased relative to visit the homes of living relatives soon after they die. Hearing, seeing, or interacting with this spirit may be reported without notable pathological sequelae. 3. Clarifying the cultural meaning of these experiences can aid in understanding the diagnostic significance of the symptom presentation. 4. Cultural mismatch between the individual and the clinician may complicate the evaluation of schizophrenia or other primary psychotic disorders. Collateral information from family, community, religious, or cultural reference groups may help clarify the diagnosis. 5. Ethnic minorities and migrants are more likely than those in the general population to receive a diagnosis of schizophrenia or other primary psychotic disorder. This may be due to misdiagnosis or to greater risk of psychosis resulting from migration traumas, social isolation, minority and acculturative stress, discrimination, and victimization. 6. Caution is advised when assessing psychotic symptoms through interpreters or in a second or third language because of the risk of misconstruing unfamiliar metaphors as delusions and natural defensiveness as paranoia or emotional blunting. Specifier scales for symptomatic manifestations of primary psychotic disorders. ICD-11 includes the option of providing a specification of the level of severity for 6 symptom domains for the disorders included in schizophrenia or other primary psychotic disorders. These domains are: 6A25.0 positive symptoms, 6A25.1 negative symptoms, 6A25.2 depressive mood symptoms, 6A25.3 manic mood symptoms, 6A25.4 psychomotor symptoms, 6A25.5 cognitive symptoms. The contribution of each of these symptom domains can be recorded in the form of specifiers, which can be rated as not present, none, mild, moderate, or severe, using the guidelines provided in the table below. The ratings should be made based on the severity of the symptoms corresponding to that domain during the past week. The descriptions corresponding to each rating in the table below are intended to convey examples of symptom presentations that would justify a rating at a particular level of severity. They are not intended to be used as required criteria. The same is true of the manic mood symptoms specifier. Symptom specifier ratings are intended to characterize the current clinical presentation among individuals diagnosed with schizophrenia or other primary psychotic disorders, and should not be used in individuals without such a diagnosis. Symptomatic manifestations of primary psychotic disorders, general guidelines for specifier severity ratings. Severity anchor points: none, excess 8H. No significant symptoms from the respective domain have been present during the past week. Mild excess 5W, symptoms in the domain have been present during the past week, but these are minimal in number or do not have a substantial degree of impact. Everyday functioning is not affected or is affected only minimally. No significant negative social or personal consequences of the symptoms. Moderate, excess 0T, a greater number of symptoms in the domain have been present during the past week or a smaller number of symptoms that have a substantial degree of impact. Everyday functioning may be moderately affected by the symptoms. There are negative social or personal consequences of the symptoms, but these are not severe. Most of the symptoms are present the majority of the time. Compared to other individuals with similar symptoms, the severity of symptoms in the domain is in the middle third. Severe, excess 25, many symptoms in the domain have been present during the past week, or a smaller number that have a severe or pervasive degree of impact, i.e., they are intense and frequent or constant. Everyday functioning is persistently impaired due to the symptoms. There are serious negative social or personal consequences. Compared to other individuals with similar symptoms, the severity of symptoms in the domain is in the most severe third. Severity unspecified. Symptoms from the respective domain have been present during the past week, but it is not possible to make a severity rating based on the available information. Thanks for watching.